and welcome from Seattle, where it's raining and we're in the midst of our rain season. Today we have a follow-up to a previous presentation on bone healing, and we have a great faculty member, Dr. Zorica speaking to us from New York, where she recently relocated. Bone healing in the form of a fusion is the ultimate reconstructive measure in spine surgery in terms of its definitive nature, and it can be so elusive, and it's undergoing ongoing changes in terms of technologies and our understanding of how to manipulate our body's physiology towards bone healing. So this is a really important topic, and we thought that we'd contrast other presentations that are corporate sponsored by an independent physician, actually not physician, but a Ph.D. who does work in an academic setting and recently relocated to New York. I'm going to introduce her separately, but she is well known to all of us in the AO community as one of our leaders in terms of basic sciences. And we thought we'd invite her to talk about bone healing and answer the many, many questions that we have around this. Ben, is Zorica live from New York? How does that sound? Ben, is Zorica live? She's on. Zorica, can I say hi to you? Can you hear me?
Yes, I can. Good morning.
I'm going to introduce you separately in great detail, but good morning to you from New York, where it's already mid-morning, right? Are you in New York?
Yes, it is. Yes, I am.
Is it raining in New York?
No, we have a sunny day.
Good. Okay, sunny days. Well, it's so nice to see you. So we always start out with some case presentations, and in my usual naive fashion, I'm going to ask you a bunch of questions that pertain to us as spine practitioners, and I'm going to also survey the chat rooms to see what questions people have. So we have 4 cases selected. They're all recent cases, and any comment of yours is most welcome. Again, there are a lot of spine technical things in there, but the main theme in all those 4 cases will illustrate an aspect of healing, and again, the questions will come towards you. Before I introduce you separately, Dr. Bouza has a unique perspective in terms of she's worked in one of the leading labs in bone healing in LA, so she knows about bone morphogenic protein and cellular products more than anybody else, probably from a very unique, truly academic perspective. So these are some of the questions we'll ask her. So the first case is going to be presented by Dr. Maurizio Avila. I frequently call him Maurizio Magnifico. So come on here and show us your first case.
Thank you, Chairman. Okay, great. Good morning, everyone. So this is a 75-year-old female who presents initially to our outpatient spine clinic in a wheelchair. She had about 2 months of rapidly decline in her bilateral extremity function, loss of dexterity in her hands, imbalance, and she was now needing assistance for all her activities of daily living. She actually moved in with one of her friends because she could not take care of herself. In the past month before her coming to clinic, she also suffered 2 falls. She said that the last one really even more precipitated her decline in function. Relevant medical history: hypertension, hyperlipidemia, hypothyroidism, PTSD, and osteoarthritis. Prior surgical history: she has an ACDF C3-6 in 2018 for cervical radiculopathy, and she had lumbar laminectomies a year prior. On exam, I just highlighted there with a star. As you can see, quite weak on her upper extremities, between 2 and 3s and even 1s on her finger abductors. She also had weakness in her legs, but less pronounced than in her arms. She had positive abnormal Huffman reflexes on bilateral upper extremities, and I just highlighted her height. She's on the short end. She's 147 centimeters. These are her plain X-rays. As you can see, her prior C3, C6 ACDF. And then these are her MRI that she presented in clinic. And on the left-hand side is a T2, middle one is the stir, and then from that stir, that's the axial cut from that line that you can see there. So basically the big thing there is at the cranial cervical junction, she has severe stenosis, and on the stir signal, you can see she has abnormal cord signal there, quite extensive, almost going intracranially into her medulla.
So, yeah, this is great. Yeah, go to CT and then we'll go.
And then this is her CT. On the left-hand side is the bone window. The middle one is this is actually like an abdominal window, but it provides us with what I want to point out here. You can see her prior C3, C6 ACDF, which most of it is healed. But basically between her occiput and her C2, there's a big, what I'm going to call pannus, that you can see on that middle image.
So Zorica, staying with the CT scan, this case has obviously a terrible problem emerging at the craniocervical junction, but I want to focus on the lower cervical spine. Briefly, so this patient has what's frequently called degenerative changes in the spine below a successful neck fusion done elsewhere. How does this happen? Is this truly degenerative, or is this some metaplasia from inflammation that's happening at those lower discs? If you look below that CT scan, below that plate, what's going on there? Is that just, quote, degenerative?
I think that's a tough one. That's a question that our Spine Society has been trying to answer for a long period of time. And actually, within our AO Knowledge Forum, we have few initiatives where we are looking at adjacent segment disease. Very often with spine fusion, as we know, especially with multi-level procedures, there is a chance, it's a risk factor for adjacent segment. And then this patient also, as outlined, had other comorbidities and risk factors that could contribute, I'm not saying to accelerate, but could contribute to adjacent segment degeneration.
So this is a very important distinction, because I think that there's clearly something else going on with this patient, and it falls into this unbridled inflammation process. And again, this is obviously mechanically induced, but this goes beyond the just usual wear and tear. If we look at the craniocervical junction at C1, C2, there's hypersclerosis, there are radiolucent cysts, and somehow in the lower cervical spine, this inflammation converted into bone, and in the upper area, it's converted into a destructive soft tissue pannus overgrowth. So just in very broad terms, when does inflammation, or what role does inflammation play in bone healing, and when does it not end up in bone healing? So somewhere there's a Y in the road, a path that leads towards bone healing, and the other one leads towards further bone destruction in this inflammation cascade. Do you know what, where, how, or what role does inflammation play in bone healing, maybe?
Absolutely. So we have various stages of bone healing, as you initially mentioned, and inflammation initially plays an important role in recruiting certain cells and helping to start that bone remodeling. But then what happens at some point, we have to move into that remodeling phase and to initiate other cascades that are not inflammation driven. And in this particular case, as the patient has osteoarthritis, obviously there is chronic inflammation, and that could extend that inflammatory pathway. And instead of proceeding to bone remodeling and new bone formation, just continue, I don't want to call it degenerative cascades, but not proper bone healing. And then it will also depend at which level, how many levels of fusion, and then which graft material has been used, because as we know, and we will discuss later, it's a very complex environment and it's not linear.
That's a great, it's not linear. So Maurizio, what was used in that old neck fusion? Do you know what graft materials they were?
I'm not sure. This looks peak to me, but I don't have the up note. We didn't have the up note, so I'm not sure.
It looks like allograft to me.
Allograft.
Yeah, there's no plastic in there. There's no titanium. There's all allograft. More questions about allograft to Dr. Buza later. So why don't you tell us what went on, because we have 4 cases. We want to move forward.
So as you were hinting, there was probably something else going on, but given her rapidly decline and her severe compression in her upper cervical spinal cord, we decided that she needed surgery. So the big discussion is the surgical options. I just put questions mark here. All posterior. Do we need to do a transnasal transoral odontoidectomy? Do we stop at C1 or do we go to the occiput? And of course, how quickly to take her surgery? Those were our big discussion points when we saw her.
And when you saw her in clinic, she presented in a wheelchair, is that right?
She did, yes, sir. And then she recently moved to her friend because she couldn't even take care of herself.
So she was being fed also?
Yeah.
Was her swallowing okay?
Her swallowing was okay per her report.
Yeah. And phonation was okay?
Phonation was okay.
Yeah. Okay. Did she sleep upright? Like in a chair?
That I don't remember.
So
I think
she did have a little bit of trouble with phonation. She had some lower cranial nerve dysfunction, swallowing problems, and her friend was feeding her.
Yeah.
She was basically was like, she was not independent.
So she's
She
an
had to have a
ASC
caregiver.
from a
Yeah.
spinal cord injury standpoint?
Absolutely.
Good. Okay. So we discussed this case heavily in our conference. Why don't you move forward in the interest of time, if you don't mind?
so. Again, our plan gave you the severe compression, her rapid progressive myelopathy, and as we were talking, wheelchair bound. We decided to admit her and for urgent surgery. Our plan was an occiput T fixation, crossing the prior ACDF and decompression with a partial suboccipital craniectomy and C1-3 laminectomies to decompress the spinal cord. This is just an intra-op snapshot. I just want to point out that this is from one of our companies, the smaller plate, and it even looks big on her occiput. And then you can see how far away the C1 and lateral masses are. So we decided to just skip the C1 and C2 screws and then fixate her from occiput C3 down. Importantly, which is the relevant part of this talk as well, as you can see on her post-op imaging, we use fibular strut grafts. So we put one horizontally, as you can see here, and one vertically in this coronal cuts to supplement her fixation and promote bone healing mainly.
So the fibulas were set onto one another?
Yeah.
So Zorica, can allograft heal to allograft?
Well, it depends. It will. It basically the allograft doesn't have any cells itself, so certainly needs other osteogenic factors, but it does provide osteoconductivity from that perspective and mechanical support.
So it's a scaffolding more or less for bone cells, but by itself, it can't heal to itself. So it's at best can serve as a surrounding platform for other bone cells to mature. Is that a fair characterization?
Yeah, that's a fair. I think that would be a fair, and I know that there were a few studies that depending on preparation, that they might contain some of the growth factors, but I truly believe it's a mechanical scaffolding support.
So the question that I also have is some manufacturers tell us that we should use freeze-dried, that it's okay to use freeze-dried allograft, and others say it should be frozen and then properly prepared. Is there a difference in terms of the quality of grafts and viability in terms of ability to heal?
From what we know from the literature and basically the evidence that the fresh frozen provide the best mechanical stability. But one of the tricky questions that we still have, although there are a lot of different allografts on the market, and certainly there have been improvements in how they are prepared, to your point, are a lot-to-lot variabilities. So it will really highly depend on the preparation that we will discuss later, and the carrier as well in some of those allografts.
And pertinent to that, does the age of the donor for allograft matter? I mean, is it worthwhile? I know there was a scandal around a Hungarian lab a couple of years ago, and the analogies to Count Dracula were immediately cropping up around the spine social media circles. But does it make sense to have an 80-year-old donor for allograft? Should there be an age cutoff?
Yes, the studies have looked at, there are some studies that even with just the bone itself, although it's more osteoconductive and mechanical support, that the bone changes as we age, and irrespective if the cells are present or growth factors are present. And then age is just one of the risk factors. Then there is smoking and some of the risk factors that even the patient in the first case had.
As far as you know, and I know you don't know all the companies, everybody screens for infectious diseases, and I'll take that as a prerogative, although recently there was a problem with a TB case that was ending up in 200 odd recipients. But in terms of these risk factors, is there any industry standard to check for quality of bone, like osteoporosis, like donor risk factors like smoking, or is that kind of not really scrutinized that much?
I do believe that some of the big producers of DBM do screen for the risk factors, and I don't know how easily available the screening tool is to the hospitals, surgeons, researchers, patients, to see as a checklist. But I do know that some of them screen. However, that screening, again, it's in a way impacted also on how they prepare those allografts, in particular DBMs.
Excellent. So what did you do for the bone graft? So from Dr. Boozer, we heard that allograft can't really heal to allograft. How did you prepare the area around it to hopefully get some bone healing?
So we did a couple of things. One is when we're doing the subocciput, we actually had a bone collector, bone dust collector, one, and then from the C1 to C3 laminectomy side, then we used that as an autograft as well. And then, of course, decorticated the lateral masses, decorticated the joints, and we also actually decorticate the fibular struts to hopefully all the cells will migrate and fuse.
All right. So, okay, right on. So let's, any insights from your end?
My insight is, I've seen fibular graft with some of you. I've never seen an occipital cervical fusion. So I just did a quick one because unfortunately for her, we don't have long-term follow-up. So I look at the one that has a long-term follow-up. This is a vascular fibular graft. And then this is how it healed in an occipital cervical fusion, which I think it looks very nice. Again, I've seen, iliac crest in this type of C1-2, but I would never seen like a fibular graft in occipital cervical fusion. So this is hopefully how it will look like. And then just in conclusion of this case, she needed 2 days in the ICU, mostly for her airway concerns. She had a difficult airway per anesthesia colleagues, and of course she had an occipital thoracic fusion. And then on day 3, when she was on the floor, she felt a dramatic improvement in her numbness and strength. And by the time the discharge to rehab, her bilateral extremities were almost 4 out of 5, and she was ambulating with a walker. And hopefully we'll have long-term follow-up, and then she'll have a nice fusion.
Rod, any thoughts from your end? I know we had an intense discussion at Indications Conference about how high to go. So what are your thoughts, C1 versus occiput? This is a very gratifying course, really nicely handled. The recovery is very satisfactory. This is why we do spine surgery. It's still a question to me why these patients can deteriorate so much. And from what I saw from the radiology reports, they were all concentrating on the wear and tear below the old fusion. Nobody looked at the craniocervical junction. So Rod, any learning points or thoughts from your end?
She was extremely unstable between occiput, C1 and C2. And we had to take a lot of bone off the posterior fossa. So I'm glad we went to the occiput. I think that was the right call.
Great. Yeah, no, given the severity of neurologic impairment, the sacrifice of that motion segment is obviously very reasonable. Thanks, Maurizio.
Yep.
Good luck traveling over to Issaquah. Maurizio works out of the Swedish Issaquah facility with Dr. Amir Abdul-Jabbar, and he has to, so thanks for coming over here. Next, we have Dr. Abe Schlotteroff, and he too has a recent case to show with questions for Dr. Boozer.
All right, so I have another case kind of somewhat similar to Mauricio's with the use of allografts. So I have an 82-year-old gentleman who has a long history of smoking, at least 1 pack per day since he was a child, so large pack year history. 2 months of neck pain prior presentation. He had bilateral upper extremity myelopathy for about 2 months, particularly when turning his head, which kind of limited his motion. He followed up with his primary care provider who ended up giving him kind of the conservative management for it. He also had progressive myelopathy symptoms during this time point. Ultimately, he was outside carrying his cat inside, fell on the stairs and fell on his face, had luckily no traumatic brain injury, but was found to have multiple pathologic fractures in his C-spine, his upper thoracic spine. On physical exam there, you can see overall pretty good strength besides some mild hand weakness. Otherwise, no hyperreflexia and normal reflexes. So here you can see preoperative imaging. On the left, you have a sagittal MRI star sequence showing that he has, starting from the bottom up, he has a T2 pathologic fracture with some retropulsion there. And then more importantly, at C6, 7, he's got NC5 as well. He's got pathologic fractures. He essentially has a planar fracture of C6 with some retropulsion. There on the coronal image, you can see the deterioration of his bone. And the axial cuts, you can also see deterioration of his bone being pushed back and very moth-eaten appearance from the tumor burden. So at this point, we're discussing possible surgical options for him. A couple points to hit. We wanted to do separation surgery so that later on he could have radiation. And also we wanted to stabilize his unstable fractures in a structurally sound manner with a 360 reconstruction so that we could fix his severe neck pain that he was having from his movement whenever he moved his neck.
I just want to point out one thing in terms of level counting. Can you take that, can you take your cursor and just show how one vertebra is basically vanished? So go in the middle, sagittal image on the CT, and just show how there's a missing vertebra. If you just correlate that with the posterior segments, you can basically see that there's a supernumerary thing. Just go from front to back. Just so go to C5, show the C5 level, one above,
C5 here.
and drag it posterior to the spinous process. Go to C5,
Oh, okay.
go one level up, yeah, and go posteriorly.
One,
yeah, just,
2, 3, 4, 5, 6.
So 6 has basically no corollary anterior vertebra. Just want to point out.
Yep.
Do you know what I'm saying?
Yep.
So this is a common mistake, like in plasmacytomas, multiple myelomas, that there's just a missing vertebra, and people totally miss that because it can literally vanish. And you always have to correlate the vertebral body with the posterior arch. So that's my point there. So this is a common problem now, and I want to point out to Dr. Boozer and our international audience, which also includes wonderful colleagues like Professor Young Hai. Dr. Young Hai, welcome, and thank you for joining us. It's great to have you with us, and so many colleagues from around the world. Dr. Jeff Kaplan, and from dear to our heart from Arizona, Dr. Robert Huang. So oncologic care is a growing problem, and one thing that you didn't mention is we immediately consulted palliative care. They're really good because we want to have a quality of life and an end-of-life directive discussion with the patient and the family. So we don't just consider these as surgical targets. But this patient was severely impaired. So Zorica, a problem for us is always bone healing and how to kind of stabilize these patients who have significant mechanical problems and emerging neurologic problems, and how long these constructs should survive. So my question to you will be, bone healing can be very hard to achieve with radiation and chemotherapy. In general, if radiation is used, how long should one wait after surgery for initial bone healing to happen?
Oh, that's a hard one. It really, I hate to say it depends. I don't like using word it depends, but with the radiation, and depending on what kind of a treatment patient had prior to spine surgery, and in this case that the whole vertebral body is missing, we are probably looking at the extended period of time. So probably not seeing anything that we are used to in first 6 weeks, 3 months with bone formation, certainly initial signs, but in this particular patient, it will be very challenging, and it will depend also on graft materials that were used here, because I'm assuming it wasn't only allograft alone with that was used. So depending if anything else was used that would enhance the fusion rate and how soon, because with radiation, bone cells, as we know, and just matrix, unfortunately, they have a huge impact that happens to those cells during radiation, especially to stem cells. And then if there is chemo involved as well, that further impacts bone-forming cells.
So I want you to hold that thought, because again, the critical thing for us in these oncologic patients, but in others also, is the vulnerable first part of bone healing, that congealment of a hematoma into an early inflammatory response, and then laying down a very primitive scaffolding for bone healing. That time period, I want to focus on that in a second. So Rod, this is an 81-year-old patient, very complex cervical thoracic disease. So C6, 7 are gone, T1 is intact, T2 is gone. Diffuse posterior disease, we could actually go down to T6. Is this just a palliative care problem at this point in time, or would we offer surgery? This man is totally with it, by the way. He's a very active, self-sufficient 81-year-old.
I mean, I think you have to look at a lot of the issues, but I think, how long does a patient have to survive? What's the long-term outcome? Even if you get a fusion, I mean, if he's going to only live for 6 months, maybe surgery is not the best option. If he's got a year, 2-year survival, and he's on board with having surgery, I think surgery is the way to go. I think the key thing is you have to make a decision now, either go big or don't do anything.
So agree. You were involved in the discussions, Dr. Slaughterov. So what kind of goes through your head as you're kind of thinking about what to offer this patient? Because there's not a simple surgical answer. There's not some little cement you can put in. There's not a brace you can put on. It's just either go big or go home, right?
Yeah. And I think it comes down to gestalt. You have to talk to the patient, talk about the options, definitely get palliative care involved, definitely get oncology involved. We staged him. He had mets elsewhere as well. So you have to make sure the patient understands, have a good heartfelt discussion about how long they're going to live and whether or not they're going to benefit from a large 360 spinal reconstruction surgery. And then it comes down to the patient. Patient's autonomy.
What did the patient want to do?
He wanted surgery. That's why we're talking about today.
Right?
Yeah.
Exactly. Yeah. So why don't you go forward so we can see what's going on?
So we did a 2-stage surgery. I'll show you films as well. The stage 1, we did a long posterior fusion from C2 to T9, and then Lammy's over the site where he had the Mets at C6, 7, and T2. And then we cabled in fibular strut graft bilaterally at C5 to T2. And then we went from the front, stage 2, to C6, 7 corpectomy with fibular strut, and then T2 corpectomy with bone cement. So here is after the stage 1, you can see sagittal and coronal CTs. I try to do a sagittal cut towards the midline so you can see the fibular strut that we cabled in there. So we cabled in to the spine process, C5, T1, and then T3 bilaterally, and then used rods on both sides. Almost did a quad rod construct with through the rods being the allograft.
So Dr. Boozer, Zorica, to Rod's statement, for us as clinicians, it would be ideal if we had a good life expectation calculator. We don't have that. This is a fast-moving field. We had a strong suspicion that this patient would have lung cancer, and I think that's what's boiling down to be. Yeah. But despite an extensive pan scanning and having multi-specialty input, we actually did not know what he had. Now comes the big question. You worked in a lab where bone morphogenic protein was heavily investigated. Why is it so undesirable? Why is it so dangerous to use BMPs in oncologic patients? What's the concern?
Well, the concern is that BMP itself, BMP2, not only BMP2, but other bone morphogenetic proteins have been involved in cancer, and not just spinal cancers, but other cancers. So depending on the pathway, these BMPs have been shown that they can initiate or enhance the cancer development. So that's why it gets challenging in cancer patients using the BMP. And there have been a lot of studies in spine field looking at the dosing. And if there is a threshold, I don't think that we have a definitive answer to that. And that was one of the reasons why, at least in our field, people hesitate, although in cases, in very challenging cases, given the positive sides of BMP, they could help in challenging environments. Like, as you said, with radiation, there is bone loss, bone density is changing. So, but it gets very challenging with patient who has cancer and multiple.
What actually happens with BMP? What thresholds does it reduce? What does it activate in oncologic disease that makes it so worrisome to kind of disinhibit suppressive mechanisms on the part of the patient? What happens ultrastructurally?
Well, it changes. So a lot of this research obviously has been done in vitro and animal models that sometimes, as we've seen without bone graft materials, and we will discuss later on, don't really translate to a clinical setting one-to-one, but there is that imbalance between osteoblasts and osteoclasts, and also where some of the stem cells and other bone progenitor cells pathways that they undertake and undergo, and then signaling cascades.
And then on this CAT scan, can you go back to the toggle back to the image? At least here we don't see the image. Can you split the screen, Ben? So the other question is allograft. So when we use a structural allograft, like here we replaced 2 of the vertebra with an allograft. We don't have, can you scan through that? Yeah, that's a good one. So we put a structural allograft in the front. At best, how does an allograft, a structural allograft, actually heal? And how much of that allograft becomes host bone? How much healing from the ends can we expect in the structural allograft?
In this patient, obviously there is also cement that provides structural support. I really, was this the immediate post-op?
This is the immediate post-op CT. This is, sorry, we don't have long-term. Yeah. This is a concept we use quite a bit for these more complex patients.
Yeah. Obviously, it gets incorporated after a period of time in this type of a patient, given that patient is exposed to radiation and chemotherapy and probably other medication. I would expect that the viability of local cells is lower. So it will definitely take a longer period of time for this to be incorporated and for new bone to develop.
Great. So we were always taught 1 centimeter can go in. Does it make sense to fill these usually hollow structural allografts with some form of a bone graft, or is that nonsense?
Can you just repeat the question if we should be?
It's allografts, these structural allografts, they're usually hollow on the inside.
Yeah.
Does it make sense to pack that full of further bone graft, or is that nonsense?
I think in a patient, again, this is a very challenging case scenario with extensive tumors and the life expectancy, very short life expectancy, unfortunately. But there have been studies where it's been, I don't know if you can call it packed, but with BMA and other graft enhancers, just to push further the use of allografts. So that very often becomes case to case and surgical team preference.
Right. So Abe, we use the structural allograft in one location at C6-7. We put cement into T2. Why was that?
So usually, again, doing a T2 corpectomy from the front can be a little difficult, but we didn't have much issues with it. We just took a malleable blade and went behind the manubrium and pretty feeble space. We were able to open it up, but we wouldn't have had the space to get a malleable allograft spacer in there or put a plate in.
It's technically very challenging. You're working around a very tight right angle.
Yeah. Yeah.
So we did something incongruous. We put a non-healing area in one area. What do we do posteriorly to try to enhance bone healing there?
So we use the fibula strut, allograft, did a good arthrodesis back there.
Yeah,
which
so we
run
actually
down
used the structure
joints.
allograft in the back and wired it to the spinous process and the compression.
Yeah.
So what happens with compression? Why is compression so important for bone healing, Zorica? So we put little cables in there, and they basically tighten the spinous processes, or tighten the fibula to the spinous processes. Is compression really that important for bone healing? Let me ask that. Or is it stability?
Yeah. I think it's a mix of both, actually. And I do think that bone cells do respond to compression in a similar or sometimes different way than disc cells. And that's why we see that application used in disc regeneration, a very different field. We actually, back at Cedars, did a pilot study where we looked at human bone marrow cells and their differentiation towards bone. And we saw that with the compression and loading, the cells responded more than just with growth factors. So certainly there is an important role of compression from a biomechanical perspective.
Great. How'd the patient do, Abe?
He did great. He has a little bit, just from the anterior approach, a little bit of mild hoarseness, which is improving, but he's eating, enjoying ice cream. He had a birthday a couple days ago, and he's doing great.
Yeah, he's actually left us already, so just a couple of days later.
Yeah. After the back surgery, surprisingly, I saw him the PACU, and he said he had no neck pain or back pain. And it was actually improved, which was pretty impressive after that large of a surgery. So he was pretty happy.
Rod, do you want to criticize us for this?
No, I mean, I think honestly, these are difficult cases, but I think, either you have to make a decision. And I think you can't do something small and I think it's going to fail.
Yeah, and he has the personality too, where he's very vivacious and very bubbly and very great demeanor for surgery like this. Still, even with the recent metastatic cancer diagnosis.
For me, it's always amazing to see the power of psyche. This man is 81. This is an undeniably major surgery, and he did so well. He had literally very minimal pain requirements, and you have patients with minimally invasive surgeries with 1-inch incisions, and there's just a large drama involved, and here he took this undeniably big surgery just in stride. It's always amazing. Just
Always a smile on his face.
Yeah. All right, thank you, Abe. Next, we'll go to a different bank of questions. This is Dr. Jared Cook, and he has a degenerative case. And Dr. Bruza sits on the AO Knowledge Forum for Degenerative Disorders, and this will pertain to a question in her domain, and she chairs the subsection on bone healing, then osteobiologics. So Jared.
Be ready for questions. Okay, so we have a 73-year-old female, comes in with a complaint of low back pain, and walking tolerance about 15 minutes because of that pain, but avid walker, very active, prior to onset of symptoms, failed all previous non-operative modalities, no prior spine surgery, non-contributory past medical history, surgeries, only a couple total knees. So importantly, her physical exam was completely normal neurologically. Did have a DEXA scan that showed a T-score of negative 1.7 on the femoral neck, but the L3 and L4 T-scores were negative 0.1. I'll show you why that's important in a minute. And notably, I measured the Hounsfield units at all levels. At the very least, they were all over 100. So this is what we see, kind of significant coronal plane deformity, but well compensated. Head is over sacrum, and minimal positive sagittal balance. And so on MRI, this is really representative of most of what we see. There's no neurologic compression on any of the MRI slices, but this is what we see on CT. So significant degenerative curve, spondylophytes, and no autofusions at those levels. Significant sclerosis, though, and so that really plays into that DEXA scan result that we get there. So at this point, kind of open to people's plans
Why
unless we
don't
want
you
to
go
move
ahead? So
on.
we will do surgery and we'll do a posterior multi-level procedure. So we can go ahead with that because we want to focus on bone healing.
Perfect. Okay, so it's a planned two-stage procedure. So stage one, to pelvis with Merceline tape tether at the UIV plus 1, and stage 2 will be an ALIF of L4, 5, and 5-1 that has not been done as of yet. So this is a recent post-op. So here are the scouts from the post-operative CT scan done with a quad rod construct, and patient does maintain the coronal balance. So
I want to go back to that. Yeah, so she's doing well. So Zorica, these massive fusions are getting more and more common. And again, they obviously get a lot of scrutiny. Do talk to us about two things. First of all, you talked about dosing of BMP. We want to have a fusion. And again, Jared, what's the non-union rate that we quote a patient with a 10-level fusion? How many levels, what's the incidence of some level not healing?
about 90%.
No, that's probably too pessimistic. Give me a realistic board answer.
About 60%.
Yeah, it's high. It's disturbingly high. It's depending on how tight your scrutiny is. So somewhere between 20 on the low end, this is Dr. Jeff Wong's famous paper, to probably about 50+% again. And we're trying to combat that with more and more rods. So BMP, is a higher dose better? Should we use more of BMP to get bone healing? Is there a sweet spot in these degenerative patients?
So, yeah, this is an extensive case, and would the BMP be the only graft material that it's used? I'm guessing it would have also some allograft, and sometimes people will pack also local bone. I think.
Yeah, you're correct. We use extensive local graft, prepare it into a bone paste on the back table, clean it, morselize it. Maybe a question about that later, and then we supplement that with allograft. So the BMP is not alone. But so is there a dose requirement per level? Have you ever calculated that? Is more better, or do we just need a little?
Well, there have been some review papers that have looked at various degenerative cases and types of procedures per level, how much you need, if it's anterior, lateral, or posterior. And there are cutoffs, but there is no, unfortunately, magic number. So and in discussions within our knowledge forum, or just with colleagues at the conferences, at many of our spine conferences, at the end, it's the team decides based on how much local bone they can pack in, what allograft they are using, is the patient at the risk, is it a heavy smoker? In this case, there is an extensive deformity. And you also mentioned that this patient had previous knee surgeries. So obviously imbalance, and there were previous issues that could have contributed. That's what we sometimes, I think, not forget, but very often with low back pain, hips, knees, neck, shoulders, where it starts first and how much it contributes to instability later. So definitely a lot of factors to consider.
So another question was, and this is also raised by Dr. Edward Donner, thank him for his contribution in the chat room. What happened with bone marrow aspirate? Just a couple of years ago, we were sold BMA devices, and there's a number of technologies for the femur and for the hips. There were little centrifuges. We actually had one of those in my previous hospital where we kind of spun things down. What happened to that? Does that actually make sense? Should we use that?
It's been still used. We did actually a long time ago, there were a few studies where retrospective looking at BMA, and when BMA is combined with other graft materials, it achieves similar fusion rates, but we don't have clinically really solid data on, like when, as you said, when we use centrifuges, when we spin down, how many cells we retain, what's the volume? Do we want to spin it down to 3 cc's and what growth factors we have. And also it depends how much we initially pull. And there have been studies that pulling 10 cc's versus more dilutes that end product that we want to have. And I think that what we will discuss later, that probably field of BMA has stemmed development of other graft materials that focus on cells primarily.
So on that topic, one more time, and then we want to move on to the next case. The other question has been always kind of, as we're preparing our grafts, how much bone graft should we actually put in? Is more bone graft better, or is there a certain kind of a minimum dose of bone graft we need to actually get healing? Does it make sense to compress bone graft? Handling bone graft makes sense to be a certain volume?
I think it has to obviously be packed well. Compressing it doesn't mean more, it's better. So it will depend on what kind of a combination we have in the space, and is it a single level? Is it instrumented? And then what?
Okay. That was
Yeah.
an audio thing, okay.
Got it.
Yeah. And what kind of a cage is if it's a instrumented fusion and there is a cage in, now there are all these surface modifications that should hopefully enhance bone healing and help with the graft material.
So one thing that we did at in my previous location, we aspirated the initial blood from the vertebral bodies. We had a little aspirator syringe, so we did not have to make separate cut downs to the pelvis. Does that make sense to aspirate vertebral bodies? I think you're a co-author on a paper that looked at viable bone cells from a vertebral body aspirate. Does that make sense to aspirate that initial pass blood?
So there are studies that show that aspirates from vertebral body have BMA cells, that they do have cells that to a certain extent are similar to what we get from the iliac crest.
So theoretically, what makes sense when we do all these pedicle screws to basically aspirate that initial blood? It could make sense, right?
It could. The only reason why I'm not just saying yes, it really depends on the protocol and how's that aspirated, how much, and how's that centrifuged and then applied back into the grafting site.
On a back table, what should we do with the bone graft that we harvest, the local bone graft? Should we pack that in blood? Should we just have that in a blood bath? Should we just dry it up? Should we put it in saline? What's the ideal local autograft protection on the back table whilst we go through a lengthy case like this?
Yeah, so actually, yeah, that's a very good point. I think the final say is not out there yet, but there have been studies showing that if it's drying out without any saline blood bath, that there is that the cell counts and that's, let's call it, cell productivity drops. So definitely there needs to be moisture, especially in the long cases like this.
How'd the patient do, Jared?
Did well. Doing great. Post update too at this point, but neurologically doing well. Back pain's well controlled. Starting to get out of bed.
Good. All right. Thank you. So final case, less than 10 minutes because we want to not cut into Dr. Buza's speaking time. Dr. Chris Seidel, thank you, Jared. And one more angle of questions now with our fourth case. These are all recent cases, so we don't have long-term bone healing signs yet, but the pertinent questions hopefully are relevant to our audience.
Okay. So this is a 64-year-old female. She presented with low back pain, tingling and numbness down to the feet, difficulty with gait, pain bilateral lower extremities, worse on the left than the right. She has a history of being assaulted about 1.5 years ago, where she sustained injuries to her back, and that's been progressive since that time. She endorsed frequent falls. At this time when we saw her, she was in a wheelchair when she was out and about, but at home she was a furniture surfer needing to get around the house. History is significant for diabetes and a current smoker. Exams notable for some weakness in her hip flexors, knee flexion, knee extension. She also assumes a forward bent posture with significantly decreased lumbar range of motion and decreased sensation in the L2-3 distribution bilaterally. So these are the CT pre-operatively on presentation. I'm gonna let them scroll through a second here. You can see she's got this L3 burst fracture with retropulsed fragment. There's an overall loss of lordosis with a flat back. End stage spondylosis at 4.5 and 5.1.
So Zorica, this is a bad burst fracture. We don't know exactly what happened. Was obviously not treated. The patient's not badly osteoporotic. She has a long-standing disc degeneration. Now she can't stand straight. Do we have scoliosis films to just show the
I did not see scoliosis.
Okay, yeah, they're somewhere, but they're a different file. So go forward to the allografting. So there's some interesting initiatives underway. Did you put those?
Do you want to see the first stage or second stage allograft?
I want to show the allograft slide that I sent you last
Oh,
night.
yes, okay.
Yeah, that was the intent here. So we did a lengthy, but there's some companies that now come out, thank you, Chris,
Yes.
that have specially prepared allografts. So they have kind of cortical bone components, but then they do some tricky stuff. They lyophilize, if I hope I pronounce that correctly, some allografts that it's kind of flexible. They do all sorts of preparations. Have you seen that? And what do you think when you have these extensive chemical preparations to allograft?
Yeah, extensive chemical preparations have been known. Again, allograft, everyone assumes it's just mechanical support. So cells, there are no cells, most of the growth factors are removed. So, but nevertheless, extensive chemical preparations, as we know, even with DBM, just the carrier itself, have been shown to impact even that mechanical scaffolding properties. And then if there are any residual growth factors or cells, chemically, they will be very disturbed and impacted.
What do you think of creating like a million little fracture healing sites, not a million, but multiple little ones, but having all these little allograft particles packed in the vertebra? I mean, the company in question is suggesting that we fill these vertebral compression fractures early on, instead of with cement, which can leak. Mm-hmm. Yeah. With the multiple allograft chains. And there are a couple of companies that are coming out with this now. What do you think of creating these myriad of little healing sites? Does that make sense to you?
So it will depend on how quickly those, I think it, from a certain perspective, definitely makes more sense than just cement, because it can hopefully incorporate well, and because bone healing is not a quick process. It obviously takes months and sometimes years to fully heal and remodel. So this would initiate that pathway quickly and early on, and then just continue as the patient receives next stages of the treatment. The only, again, without having seen all the evidence on this, the only worry I have is patient the stability. Are we talking a single level case, or is it a multi-level case? Is it just a degen, or if there is deformity? And then for this particular patient, if I can just relate it to this particular patient, I think that patient is a smoker. And also, given that the injury happened, unfortunately, due to an assault, we've seen that in patients, especially with low back pain and degenerative cases who have mental disorders such as depression and anxiety, that really literature has shown that plays a huge role when it comes to fusion and outcomes, that actually depression and anxiety have their own ways impacting bone remodeling, and especially if there are antidepressants. I don't know if this patient.
That is an awesome point. So Dr. Hart, does this make sense to you to pack a vertebral body in a hypothetical world? If it's spin back time, she presented with an early burst fracture. Does it make sense to pack this up with, instead of cement, with all these little bone corpuscles?
Well, this is the first time I'm actually encountering this device. I hadn't heard of it. Certainly, it makes better biologic sense, it seems, than cement does, which never remodels, never goes away. Maybe that's not a bad thing, but the question I would have is in terms of the mechanical stability. Is it as stable as cement? And cement certainly does that nicely, fills the void very nicely. I don't know, I'd have to try it. I think it's an interesting idea. I wanted to apologize for my late arrival. I woke up to a flat tire today, so I'm so
You
sorry.
mean Tesla does not have electric tires yet?
Not yet electric tires.
Can you pass the microphone to Dr. Glenn David? So he's a nationally renowned specialist for interventional spine management, cement application versus bone graft. Does this make sense to you? You've had great successes, and the paradigm has shifted towards early intervention with cement. Does this make sense to you, kind of put allograft in there and try to pack it in as tightly as possible? Is this something you'd look at?
It's something I look at. It's like what Bob was saying, is that are we able to provide some stability to the bone with this allograft is the question. As Bob was saying, yeah, the cement provides some stability to the matrix there, and whether or not this in the long run will provide that is the question.
Yeah. All right, no, thanks. So go ahead with the surgery then. We need to conclude. We have like 2 minutes time. So what do we do? And maybe Dr. Hart, as an independent observer who doesn't see this case, can critique us, because this is a co-production between Dr. Oskuyan and myself. So let's go ahead with the pictures.
Okay, so we decided to do this in 2 stages. So first stage was long fusion from T9 down to the pelvis with inner bodies at 4.551 and laminectomies in between to allow for decompression. Second stage was L3 corpectomy with a large cage placed. You can see we have very good fill once we get through. There you go.
So Zorica, stress shielding. We talked about compression being good for bone healing, and some stability is good, but some instability incites bone healing. What are your thoughts in terms of, can we put too much metal in there and just shield bone too much from getting a healing impulse? Is that a factor?
Some of the, I believe, yes, I believe so. It really is a balance, and there have been, again, animal models that have looked at it from both biological and biomechanical perspective. And it can certainly have an impact on how the bone will remodel.
And Dr. Hart, so give us your critique on what we've done here. Too much, too little, just fire away.
No, I'm a big proponent of quad rods now, so I like that. I like inner bodies at the bottom with a long construct fused to pelvis. I really like staging doing the big posterior operation first, like you did here. How long was there between the posterior and the anterior?
First stage was Friday, second stage was Monday.
So you didn't delay it. And that's fine too. I probably would have delayed that several weeks in between. I like doing that because it lets the patient recover from kind of the big physiologic impact of the large surgery. I'm a little bit curious, looking at the coronals, it looks like the gap between 2 and 4 is still quite tilted, and I'm surprised. Is that she looks balanced, but she must have been well out of coronal balance.
She was out of coronal balance. This is a complex deformity. She had actually collapsed the lumbosacral junction eccentrically, and she's kind of offset. So this is something that I still work with. I use some modification of your rod. I use a Bovie cable, but also this clinical assessment to try to straighten the patients out in surgery. But I would love to have a tech solution with a intraoperative navigation guide for coronal and sagittal balance, to be frank. But she clinically is actually straight, and on the reformats she looks straight. But this was that L3 burst fracture had eccentrically collapsed. So she literally was kind of like, there's a scoliosis film somewhere. That's why I was asking for it to show that, but that's okay. We don't have to look for it. So far she's doing well?
Yep, doing well so far, recovering as expected. Post-op day 2, obviously, from stage 2. So.
Great. Thank you, Chris. So we'll move forward to our wonderful guest speaker, Dr. Zorica Boozer. She's a Ph.D. and M.B.A., and I could spend the next 10 minutes introducing her. She has multiple amazing accomplishments to report. She recently did something amazing. She moved from LA, where she was director of the research lab at USC with Dr. Wong, one of the leading bone healing and basic sciences labs in orthopedics, to New York to join Dr. Gerling for the innovatively named Gerling Institute. It should be the Boozer Institute as far as I'm concerned. Zorica is a PhD from the University of Ulm. I'm heavily conflicted. She has done extensive work in biomechanics and osteobiology, multiple publications in the hundreds. And she works literally with all the major societies. I think she's actually the chair of the Osteobiologics Committee of NAS. She works in the AO Degenerative Knowledge Forum and is one of the leaders in terms of the AO Basic Sciences group. She is a reviewer, watch out to our fellows, in literally all major journals, and has a leadership function in that. And she's always a delight to interact with because she is very straightforward. She says it as it is. And so we thought we'd ask her to review on her experiences with bone healing and how we can accommodate bone healing, and just ask her some straight up questions without any industry bias. Zorica, thanks for joining us, and congratulations on your new move to New York. I hope it'll be a rewarding one like your entire career path has been. So thanks for joining us, and we're looking forward to having a big picture review on bone healing.
Thank you so much. It's really I would like to thank for the invite, and it's honor being today with everyone, and really looking forward to future discussions. So I'm just going to quickly go into the presentation mode. So really this was a great presentation so far with all the cases, because it feeds well into the next 15-20 minutes, and I look forward to our discussion really on cutting to the chase, understanding what works and doesn't, and as we can see, it's not just a straight answer. Here are my disclosures. Really, none of them are relevant, or there is no conflict for today's presentation. So through all these 4 cases, we've really seen how do we address the question of osteobiologics, what works, and how much do we put in, what level of evidence we need. And I think the very first one is who is asking the question. And we've seen that through the 4 cases, we have a various stakeholders involved. It's a very lengthy list. I try to summarize it, and it doesn't really only depend who's asking the question, but what kind of a question and how they ask the question. A couple of years ago, just as an example, we had a patient who was getting a lumbar spine fusion for a degenerative case. It wasn't even a deformity case. And the patient wanted the most superior graft material placed. So the question is, how do we define the most superior graft material? So it's really important, and that's what this whole presentation, next 15-20 minutes, is going to focus on. Who is asking the questions, how we can help all these different stakeholders, and also how we can really understand what graft materials we currently have, what do they do, and how well they do that job. And then the second one, which we've addressed through some of the presentations today, is how do we measure that success so that we can truly say, okay, this graft material works at this concentration or at this volume. So just to take a step back, I think I always like to look at things globally and big picture, because that's what our stakeholders who are asking the question about osteobiologics want to see as well. And this was one of the, without going into great details, recently published studies a couple of years ago in JAMA looking at the healthcare spendings here in the United States. It's a busy graph, but what we have to focus on, it's these orange bars that show how much we spend in the United States. This was in 2016 on low back and neck pain problem. As we know, they are leading causes of disability worldwide. And we can see when we sum up public, private, and out-of-pocket payments, it totals to over 120 billion. So it's certainly very important to have graft materials in our spinal procedure, irrespective if they are surgical or injections or conservative treatments, to the best success for our patients. And then we've discussed that in the cases this morning as well. We've constantly, and there is really a lot of literature out there showing that there has been an increase in both cervical and lumbar spine fusion procedures. But then the non-reunion rates, we don't have that exact number. They really vary from a couple of percent to 40%. And this is some just most recent literature that this, for example, paper has looked at when the non-union happens in cervical cases, and the majority, the percent of 12, 13% happens within that first year and then kind of plateaus out to the second year. And this is another study in the Spine Journal, also recently published by Lambrecht and co-workers, where they looked at, okay, we have a primary, we have a revision surgery, busy table, but they're just showing some differences in the approaches, and also that patient outcomes, that obviously after revision surgery, there is a higher risk of complications, lower patient-reported outcomes, both from pain and disability perspective. So all of this really ties back to how do we address the question what osteobiologics do and how well they do it and how we can prevent future revisions. So then just as another, as we focus on osteobiologics, these are just some bullet points that I think for us are important to know. To Jens' question before, is there too much instrumentation? Osteobiologics are a very important component to spinal fusion. Actually, they're at the forefront of that spinal fusion to happen. So it's important to look at their global perspective, and we are continuing to see increase in osteobiologic use, different types of osteobiologics, and these are just some statistics. And what's also interesting to see is that previously it was very focused for North America, and that trend is in Europe, but that trend is changing, and actually Asia Pacific is also showing higher compound annual growth rates when it comes to the use of osteobiologics. So what initiates use of osteobiologics and the increase? Obviously, we've seen, as I mentioned this morning, we constantly advance spine and spine surgery. There are always new devices, instrumentations, approaches we use, minimally invasive or open, and that also dictates how much osteobiologic, or maybe for MIS cases, which osteobiologic to use in that small space. But what we sometimes forget, and we are really trying through some different initiatives to look at that, are the patient risk factors. And we discussed that this morning with all of the cases, actually. And these are just some CDC quick facts on some of the leading risk factors among our population. Osteoporosis, arthritis, smoking, all contribute not to only bone, host bone itself, but how that bone remodeling and new bone formation is going to happen. And then we should really not forget, was there a question? We shouldn't forget the cells. Because, and this is a study done by Bruder in '97, and this is important to keep as we discuss BMA or cell-based graft materials, that human stem cells.
Please, Ben, please mute the other speakers. Please.
Thank you.
Dr. Boozer, thank you.
Thank you. So we shouldn't forget that obviously the number of cells changes to the discussions we had this morning as well. How many cells we need, and when we are looking at the graft materials that have cells, is there really a cutoff at age? So you can see just from this graph that substantially reduces as we age, and not only that the numbers reduce, but those so-called active cells are not as active as in younger individuals. And these are just some osteobiologic trends. This is a story of ICD billing codes. What we use, it's one of the databases, and just shows over the years that obviously autografts are still used in large amounts in both single and multi-level procedures. Then there are non-autologous, obviously BMP, as we know, is used in various degenerative deformity cases when it comes, and then synthetic materials as well. So where do we stand, and how can we answer, going back to that third slide, having different stakeholders, what works and what doesn't? So and we mentioned that this morning, we do have a checklist, and ideal graft material should have it all. But we always have to remember that bone remodeling and bone formation is not a linear behavior. It's not a linear thing that by adding osteoconductive, osteoinductive, and osteogenic, the magic's going to happen and bone is going to fuse. There is really a lot. It's a complex system. So we have to pay attention and always consider all the elements of patient comorbidities, how many levels, are we using cage and instrumentation? Is there anything else that might impact that bone fusion? So now really dialing down to what works and what doesn't and trying to tease out that evidence. This is a very busy slide and confusing, as is our field of osteobiologics, but these were some of the efforts that we did within our AO Knowledge Forum. We looked at all graft materials over the last 6 years and published various systematic reviews. And what you can see, really what boils down, where on the left-hand side is the study quality, that there is barely any, to a lot of study quality on the right-hand side, and then up and down it's fusion, existence on not existence, fusion. You see that most of the research and most of the clinical evidence on various osteobiologics kind of is stacked on the left-hand side, which means that we have a low quality of studies, small sample sizes, very often high risk of bias and inconsistent reporting. So what that really leads is to, when we look at these osteobiologics and what we are currently using, is what else do we need to finally have that yes, no answer? This works for this case scenario, and this is how much we should use. So just as a quick overview, really big picture where we currently stand with the BMP2. There is a bone, as we are all well aware of, bone initiative for posterior lumbar fusion and TLIF. It's a dose. These are two clinical trials and dosing studies. The one for TLIF, it's around 1,000 patients. They're still enrolling, and the results, believe they're closing in 2025. So in a couple of years, we will have results on that study. And this is for posterior lumbar fusion. Also coming in next years, it's also a dosing and safety study, because as we well know and discussed this morning, BMP has been used off-label in both cervical lumbar procedures, single, multi-level, and also in the deformity. Actually, some recent studies looked at the cost effectiveness in deformity cases with BMP. When it comes to small molecules, I have listed the ones that have been present, but most of them are really in vitro and basic science. The only one that has been in clinical use is I-factor, and there are several studies where they've looked at ACDF and lumbar cases, and a recent study on the cost effectiveness. When it comes to synthetics and bioactive materials, they are used because they are easily available, inexpensive, but they have, as we know, and they're really available in large amounts, but from a biomechanical perspective, they represent a huge challenge because they're resorb faster than bone. And we've discussed that this morning as well. When do we see that bone remodeling? When it becomes part of the host bone. And so it's really important to keep that in mind as we are discussing this with our patients, as we are planning, and also from a insurance and research perspective. And then bioactive materials, it's really the chemistry that makes them bioactive. There are no cells or growth factors that are internal, except if they are added to enhance. And calcium phosphate with silicon and bioactive glass have been the one that have been most present. And we've done some research within our knowledge forum, and again came up with the final conclusion that the evidence for use of synthetics while they're heavily used is very limited, and that we need more clinical resources and data to really see when those, especially bioactive second and third generation graft materials, can be used. We've discussed heavily this morning allograft and DBM. And again, what we've done through our analysis within the Knowledge Forum is that when we look at the DBM and allograft, we have to consider instrumented versus non-instrumented fusions. And we've started in this systematic review with almost 700 clinical studies, arrived with 17 that were usable. And as we can see that the fusion rates really vary. And that is the second question that we really have to always keep in mind when we are trying to answer what biologic works and for what condition. How do we measure that success? And the last couple of slides will focus on that. But we've found that the fusion rates vary with the use of DBM and allograft, and that it's anything between 60 to 100%. And then in non-instrumented fusions, as we know, DBM and allograft don't produce as high fusion rates as autograft and maybe some other enhancers. And what's also important to mention, there has been, as we've seen, a lot of development with various DBMs. There is a lot of different DBM products on the market. And in the last couple of years, really the clinical evidence that has focused is not only on the lot-to-lot differences, but how to reduce the amount of carrier, because very often that's one of the disadvantages with the DBM. And also to really look at, when we look at the DBM, is it a fiber or particle based? And some studies have shown that a fiber does better and can produce up to 100% fusion rates compared to the particle based DBM. So definitely there has been a lot of advancements when it comes to DBM, and DBM, I don't think it's comparable to synthetics, that it's the same cost, but definitely it's readily, easily available, and it's less expensive than other osteobiologics. So just briefly, I think there has been in the recent 2 years a lot of discussion around cell-based scaffolds, and some of the recent market trends have shown that that spike in use of cell-based scaffolds has changed and has dropped. This was a study that we published recently in JBJS. We actually wanted to see what those cells really do in the cell-based scaffolds and how much they, again, it's not a linear behavior, so we can't really do black and white comparisons, but do they truly contribute, or is it more of a mix of that complex environment? And long story short, what this table really shows you a snapshot of our results. We had groups, we had two types of CBMs compared to DBM, and we took those cellular-based scaffolds, divided them, instructions for use, and in one half we removed cells, and then implanted the scaffolds with and without cells. And what we found at the end, without going into great detail, none of the scaffolds with cells fused on CT. When we looked at CT, manual palpation is again very can be biased, but we didn't see differences between the scaffolds who had cells and the ones who were devitalized and did not have cells. So based on that, we couldn't really conclude that at least in our study, the cells in those scaffolds did anything. And the interesting part with some of those scaffolds, again, as we talk about fibers and particle DBM components, it's also important to keep, but something to discuss when we talk also about the autograft, and as the graft preparation for placing it in that fusion bed is like the chip size and how big or how small. Is there a cutoff on that? What we did notice with some of these cell-based graft materials in our study, and this is just the fusion site, as you can see, there were some big bone chips in there that were creating this membrane around it that was preventing bone growth. So that has to be also considered as we prepare our graft material for placement. How big are the chips, where they are positioned, are they close to the bleeding bone? So really important, because in those fusion sites, we saw that there was no bone formation around this material. So that was an animal study that looked at what cells really do, but we then, within our knowledge forum, took a step further and really looked at all different allogenic stem cell graft materials that are used in spinal fusion, both cervical and lumbar. And we arrived only at 11 studies that have used these graft materials. And this is the list of the graft materials that we had. The final conclusion was, again, very low level of evidence and on effectiveness and safety. So in just last couple of minutes, what I would like to do and spend for us to open the discussion as well is some of the initiatives that we've been trying. Field of osteobiologics is very confused. And it's not a black and white picture that we can say this one works, this one doesn't, but all of the, as we said, stakeholders and our patients, and we do need to have some guideline that will help us decide when it comes to the treatments. So what we've done within our knowledge forum, we've developed a bone classification that and it's based on evidence and has 3 levels of evidence. And our hope is we are in the stages now of validation and leading it through the Delphi process. So hopefully some of you will be involved with that. But what we are really hoping is to bring all different players at the same table and in that discussion, and to simplify the field of osteobiologics so that a fellow or a junior surgeon who maybe is not in a big academic center can decide what is the best for their patient, and so can regulatory and also patients can better understand what our current osteobiologics do and how well they do that. And we hope that our bone classification will help with that. And we took it a step further actually and developed, we just finished AO guideline within our AO knowledge forum where we looked at developed the guideline. It's an international guideline and an effort of a large group over the last year and a half, where we developed a guideline on the use of osteobiologics in ACDF. So I'm hoping for our next discussion, we can use this AO guideline and better define what graft material might be more suitable for individual cases. So this really, the last minute or so, while we have different osteobiologics and we are trying to understand what works, what doesn't, how do we define that success? And as if you remember our third slide, a lot of research has been done for cervical spine, not so much lumbar. And this is efforts of Dan Rue and his collaborators. They have published really a lot, but they have looked at the fusion criteria within ACDF and how do we define that success? And these are just some of the most common criteria that we use when we look at the CTs and radiographs. But let's look at this graph. There is so much variability depending on which criteria for fusion we use. And is it only one or is it the other? So the bridging bone, that is the most common, as we can see, it has a high variability. And then that feeds back into what works. It's really important to know what criteria we use to define what works. And then this was another study. I'm just kind of going quickly through these, that not only depends what fusion criteria we use, but what graft material we use. And then an interesting study depends who evaluates that fusion and looks at the graft material and how they evaluate it. And in this study, they actually found that there was a disagreement at 6 months between when independent observers evaluated the cases, and that disagreement was more pronounced depending on if patient-reported outcome were included in the analysis of what fusion works, what fusion was successful fusion and where there was non-union. So really to close and open the discussion for us, and these were some of the questions that we constantly use within our knowledge forum, is I think these are really key questions that we have to ask every time when we are evaluating osteobiologics to come to that conclusion, what works, what doesn't. Is it really effective as others? What are the complication and safety profiles that very often we don't know? And how about patient comorbidities? And then at the end as well, the costs. And with that, I'll close my presentation. Thank you.
Thank you. Accept our applause digitally and online and with our global audience. Really cool and well done. So you have a unique perspective, and I want to again recognize the incredible efforts you've done through AO and the power of our global surgeon community to kind of structure this whole amorphous field. and get us some insights. Can you tell us why nicotine is so bad for bone healing? Or I'll rephrase it, is nicotine really that bad for bone healing?
So we've seen from the research that we've done and the literature, the evidence is still conflicting. Definitely nicotine does play a role in osteoblasts, in that cell environment, and how their impact and possibility to create the bone, without going into great detail on the basic science. However, clinical studies have still conflicting results to that. And that's why I think certain, like back at USC, we had an 8-week cutoff that patients had to stop prior to surgery. Some people, I've seen that people will allow smokers to undergo immediately spine surgery without cessation. But what research shows is that it definitely impacts the osteoblasts, also impacts bone quality overall of that host bone.
And same question for osteoporosis. Badly osteoporotic patients, do they have impaired bone healing? Yes or no?
Yes. Yeah. They do. I mean, they do, unfortunately. And if it's again, and also depending on what medication they take and if there is anything else going on. So definitely the host bone will have a challenge, use of autograft alone to repair and remodel, especially complex cases.
My partner, Dr. Hart, is with the ISSG, and he has some questions also. He's obviously studied bone healing with his platform very intensely.
Yeah, a couple questions. That was really a great talk, and you know, it brings rigorous science to a field that has badly needed it, in my opinion, for some time. So congratulations on that. I have a couple of quick questions. One is, do you have an opinion regarding biomaterials for interbody implants, and in particular PEEK? I think our clinical experience and some research seems to be showing that that's not a very effective interbody device for fusion. Titanium, and particularly now 3D printed titanium, may be better, but then bone itself is still a strong contender as well. So do you have an opinion about that, and is there evidence? And the second question I have is about pharmaceuticals, and you know, we try to make a strong push to get patients on anabolic agents if they've got bone density issues preoperatively, for long fusions at least. So, but these are still very expensive, and it's hard to get approvals if they don't have frank osteoporosis. I'd love to be able to get it for osteopenic patients. And how big of a difference does that make, anabolic pharmaceutical agents versus bisphosphonates, in your opinion?
Yeah, thank you. Excellent questions. And there is a constant debate between osteobiologics and PEEK and titanium, and especially now, like, how do we couple these two, and what is that magic formula for them to work together in a host bone? To your point, and I agree, the recent evidence shows that with surface modifications, and that especially with the 3D printing, that hopefully we will be able to simulate host bone even better than just a block of, and I'm not trying to simplify it and say a block of metal, but that will then hopefully reduce the amount of osteobiologics we need, especially in healthy patients, or maybe help us define those cutoffs for osteobiologics, because as you mentioned, cells need something to attach to start forming the bone. So if we can modify the surfaces and hopefully introduce other chemistry to it, definitely it would help with the osteobiologics. When it comes to the anabolics and bisphosphonates. We have done, for that, agree, limited evidence in the sense that there is no clear yes or no. And I think one of the issues is that we don't have large of a population to study that yet. It's very heterogeneous, and we've done some studies where we've looked at bisphosphonates and if there are differences in revision rates, complications compared to other anabolic agents. These were database studies, so with limitations, and the differences we've seen were unfortunately not significant to point in one or the other direction. And that's where I think we are, from insurance perspective, still struggling, because for something to be approved, they want it black and white. And in our spine field, that's very often challenging.
I was told to let you go at 8 o'clock sharp. And Angela runs our ship with a very tight rule. So I begrudgingly have to let you go, but that was really, really cool. Very, very quick question. Multiple people have pinged, so just one question. Yeah. BMP, just a quick answer, BMP and avascular necrosis early on, does that make sense before the head collapses? One of the attendees wants to know that. Does that make sense to you? Avascular necrosis in the head?
No, it doesn't, but I would, yeah.
It doesn't make sense to me, but yeah.
Yeah.
We have to probably look forward to re-engaging with you in the future again. That was so cool to hear you, and to your big picture perspective is so refreshing, and your efforts at putting structure in this field, like what Dr. Hart said, is really commendable. So thank you for your time and effort. Wish you all the best with the Girling Institute, which I still say should be the Boozer Girling Institute, and stay in touch. All the best to you. Thank you so much.
Thank you for having me. Pleasure seeing everyone. Thank you.
She's great.